coming to you from the gym because I had a little lull in the action here. I had a patient call in sick, so I wanted to cover something with you guys that I posted yesterday on Instagram. And I posted a reel yesterday that I've posted multiple times. I try to post this at least once a year so I can see all of the conventional clinicians and all of the PT students that have totally bought into being brainwashed by their professors. I like to watch them get their panties in a bunch and just get totally mind fucked about what's going on in this reel, even though it's basics. Like, this is stuff that you should have learned in undergrad, and then they should have reviewed this really quickly in PT school, like, oh, everybody knows this, we're just gonna review, just to remind you that this is the way things work. So if you missed the reel, I would go back and watch that reel after I talk about this, because you'll see the interesting thing is all the idiotic, moronic comments that are made by PTs that think they know more than what I posted in the video, which is mind-boggling. So the point of the video is to remind clinicians and students that the primary function of the soleus is to control anterior translation of the tibia, which is a component of knee flexion. Pretty basic, okay? Soleus connects the tibia, so it comes off of the posterior tibia, attaches through the Achilles tendon to the calcaneus. When you go into knee flexion, the tibia comes forward into anterior translation, and the soleus is eccentrically lengthening during that phase, which means that the soleus is a eccentrically loaded controller of knee flexion, much more than it is a plantar flexor. So the whole point of the video is keep this in mind when you're working with ankle sprains in this case, that if you're going to be working with ankle sprains, you need to assess the soleus to make sure that it's controlling eccentric loading of the knee in knee flexion, which if you put all that stuff together, the primary function of the soleus is knee flexion. Pretty basic stuff. Anatomy, biomechanics, a little bit of critical thinking, put that stuff together and you know exactly what I'm talking about. So the comments or the questions, more comments than questions, because once you graduate from PT school, you are anointed a doctor who knows everything that you need to know because school taught you everything you need to know. Now, if you're watching this, you know that's total bullshit. So the comments that people make because they think they're experts sounded something like this. So the soleus has nothing to do with knee flexion because it doesn't cross the knee. And then the same comment from the same person, well, we know that the soleus controls, attaches to the tibia and controls anterior tibial translations. So wait a second. If you admit that the soleus connects to the posterior aspect of the tibia and eccentrically controls tibial anterior translation during knee flexion, you've just told me that the soleus is a knee flexor. Not sure what that guy doesn't understand, but that's fact, okay? So keep in mind, a muscle does not have to cross a joint in order to influence that joint motion during some kind of functional activity. Okay, so I agree, the soleus does not cross the knee, but it attaches to one of the three bones that makes up the knee, which means it is a major influencer of what is happening at the knee, even though it doesn't cross the joint, okay? Another one, the best way to train the soleus is to put the knee in 90 degrees of flexion and then do plantar flexion. And that's what you should do to isolate the soleus. Well, genius, the reel was not about isolating the soleus. I didn't say that the best way to isolate the soleus is to do squats and lunges. What I said was, when you do squats and lunges, you're going into knee flexion, which recruits the soleus to help you get into knee flexion and dorsiflexion, which in this case, when you're talking about ankle sprains, these people lack dorsiflexion. So rather than trying to move them, mob them, do whatever, stretch them into dorsiflexion, what you should be doing is assessing the soleus for neuromuscular function. When it shows inhibited, you should reverse it and reestablish normal neuromuscular facilitation, which will increase knee flexion and dorsiflexion for the long term because you've reestablished normal neuromuscular function rather than just doing stretching and mobs, which does nothing once the patient leaves the clinic. Okay? So if I would have said, hey, if you're a competitive plantar flexor with your knee in flexion, the best way to increase your strength for your competitions where you go sit on a bench and do plantar flexion with your knee flexed is to do squats and lunges, I would be wrong. What I should say for those people that compete in that, which by the way doesn't exist, is to sit there on the Soleus machine and just do plantar flexion. Okay? We are talking about muscle function. Muscles do not function by themselves. So trying to put a patient in a position where you are getting a muscle in isolation is not doing them any favors. The only time you should be putting a muscle in isolation and doing an exercise for it is if you're doing submaximal repeated isometrics in a specific position for that specific muscle, which will increase neuromuscular function, which is why we use isometrics for a specific reason when we're giving patients home exercise programs. I have never given a patient a seated plantar flexion exercise for their soleus because I wanted to isolate their soleus, because that has absolutely nothing to do with anything. Okay? My favorite one is when people say, well, you're just doing this to show off and make things complicated. No, what I'm actually doing is reminding you that you should know this. And from the comments in the comment section, most people don't even understand this to begin with. It's not even a review. All I'm doing is putting this out there so you review and remember when you're working with these patients, don't forget about this. And it's mind fucking 75% of the people that are watching this because they don't understand what I'm talking about, because they never learned this, because in anatomy class, you learn that the soleus is a plantar flexor, boom, that's it, move on. Origin insertion, action in the anatomical position without doing anything functionally, without gravity, without weight bearing, without transverse plane, which means what you're learning for your action of your muscles in anatomy class is pretty much useless, unless you're going on Jeopardy and they're asking you questions about actions of muscles. Okay? So I'm not making it, if that reel, so if you haven't watched the reel, go watch the reel. If that reel and the caption to that reel is complicated to you, then you need to go back and review biomechanics and anatomy. I'm not doing it to make it complicated. I'm just doing it to make sure that you actually remember this, which the same guy made the next statement that, well, everybody, are you telling me that physical therapists don't do squats and lunges with their patients? Everybody does squats and lunges. That's nice. The important thing is to know why you're doing squats and lunges. And so if I came into your clinic and you had an ankle sprain patient that lacked dorsiflexion and you were doing squats and lunges and I said, why are you doing that? And your answer is, well, don't you know? We always do that. Golly, the handout said it. That means you don't know what the hell you're doing. Okay, so it's not important to do the exercise. The important thing is to understand why you are doing the exercise. And if you don't know why you're doing the exercise, and the only reason why you're doing the exercise is because somebody told you, that's what the protocol says, that's what the handout says, that's what you saw somebody else do, you need to stop treating patients and go figure out why you're doing what you're doing. I never do anything with a patient without thinking about, this is the purpose of what I'm going to do with this patient. That's why patients get better. When you don't think about what you're doing and you just follow what everybody else is doing, and most of what everybody else is doing is pure fuckery, that's when you screw your patient over. That's when your career goes downhill, because you don't know what you're doing. You're just going through the motions, and your patients figure that out, and that's why they don't come back. And then somebody else said, well, you know, if you're in an anatomy class, if you're teaching an anatomy class, are you going to teach them that the soleus's primary function is knee flexion? And I would say yes. I would say, okay, so if you're going to get asked a question on a trivia show or on boards, what the function of the soleus is in some kind of anatomical position, floating man on a chart, you're going to say plantar flexion. So this is what I teach my students that are coming through as PT students and they're doing their rotation. Here's the answer that you're going to have to regurgitate on a test, which is wrong. Here's the correct answer, which is what you're going to use in the clinic. So understand, Clinical skills are not the same as educational regurgitation on a test. Two different things. So understand what you have to regurgitate on the test to pass the test, but then understand once you pass the test, you can forget that and you can start thinking like a clinician. So that's the takeaway from that. So once again, if you didn't see the reel, go watch the reel, take a look at the comments. I tried to be nice. I tried to help people out and be as nice as I could, explaining my position that I'm talking about function. I'm not talking about floating man chart, that I'm talking about what really happens when people do an exercise and we have a closed chain environment and we're talking about eccentrically loading a joint to get in a position either of knee flexion or dorsiflexion. So that's where I'm coming from. Not coming from competitive plantar flexion soleus lifters, which doesn't exist. So you don't need to be putting people on the little soleus calf raise machine. Now, if you have a healthy population and they're going to do that stuff because they want to work on soleus strength, which I don't work on strength with people in the clinic. People in the clinic don't have facilitation. So until they have facilitation, I would not go and try to work on strength. It's facilitation. It's reinforce the facilitation so we break their compensation patterns. Then it's work on muscle endurance, because if that muscle has been inhibited for long enough, now the muscle doesn't have endurance, so we have to work on endurance before strength. The last thing we work on is strength. If you're a PT that's trying to increase strength with your patients that are coming in to see you twice a week for a half an hour, you are never going to increase strength or cause hypertrophy by doing what you are doing. You should be focusing on facilitation, then reinforcing normal patterns, which is patient specific, not textbook specific. Then you should be working on muscle endurance. Then you should be working on strength. So by the time they get to the strength component, you've probably already discharged them. They're probably already gone. So you're not working on hypertrophy with any of your patients. Don't forget that. So watch that. Post comments down here or post comments on the reel if you have questions about what I'm talking about. But hopefully that makes sense. And the big thing if I could get you guys to do one thing, the one thing would be understand why you're doing what you're doing every time you do something. Stop going through the emotions. Stop doing things that somebody told you. If we stopped doing that shit as physical therapists 50 years ago, we wouldn't have cupping, we wouldn't have needling, we wouldn't have neuromuscular stimulation, we wouldn't have orthotics, we wouldn't have stretching, we wouldn't have Theragun, we wouldn't have all this bullshit because 30 years ago, somebody actually thought about, why am I doing this and what does this have to do with proven physiology, anatomy, biomechanics? And can I critically think through a process to actually use those things to my advantage? That's my take-home message. Think about everything that you do in the clinic. And if you can't rationalize a reason why you're doing it, stop doing it and figure out why.